welcome to the 4th Annual AAKP National Patient Meeting. It is a thrill to be back in person and to see so many familiar faces again. A warm hello to everyone joining us virtually as well. Thank you for being part of our community through our event platform. Your participation making this gathering even more special. My name is David Rodriguez, and I am a proud kidney and liver transplant recipient from the state of Texas. I have had the honor of serving on the AAKP National Board of Directors and as an AAKP Ambassador since 2017. These roles have given me the invaluable opportunity to advocate for patients like myself, ensuring that voices are heard and their needs are met. My professional background as a former patient relationship specialist at the University Transplant Institute in San Antonio, Texas, has significantly shaped my approach for patient advocacy. Through strategic planning in vulnerable areas and my experience in visiting dialysis treatment centers throughout my career, I have been deeply involved in public speaking to a broader Spanish-speaking audience and in networking and building relationships between healthcare professionals. These experiences have enabled me to better understand the complexities of healthcare and advocate effectively for policies that improve patient care and outcomes. As a proud member for AAKP, I firmly believe that every kidney patient's voice is paramount in determining their care plan. It is essential that we cultivate an environment that encourages kidney disease research and innovation, driving continuous advancements in care, improved treatments, and solutions for unmet patients' needs. Once these innovations receive FDA approval, it is equally important that all patients have access to and the right to choose the best treatment for them in consultation with their chosen healthcare team. This ensures every patient can live their best life and achieve their aspirations. With that, it is my honor to introduce our next session, titled Innovation and Research, Incremental versus Conventional Dialysis. What does research show? At AAKP, we are strong advocates for patient care, choice, and innovation in dialysis care. AAKP view dialysis as a bridge to transplantation when an individual is medically eligible for a kidney transplant. That means we must ensure that individuals on dialysis remain as healthy as possible. And this is being done through home dialysis options, as well as new research into incremental dialysis, which is what we will learn more about today. Through collaboration with researchers, healthcare professionals, and industry leaders, AAKP plays a pivotal role in advancing the conversation of advancements in dialysis and ensuring that patients have access to the latest evidence-based information. Today, we are honored to welcome a valued friend and distinguished guest, Dr. Mariana Murea. Dr. Murea is an associate professor at Wake Forest University School of Medicine in North Carolina and specializes in clinical research and hemodialysis. She serves as the lead principal investigator of the 2+ trial study, which is funded by the Patient-Centered Outcomes Research Institute. AAKP is proud to be a stakeholder within this valuable study, which aims to compare individualized incremental start hemodialysis with conventional hemodialysis, reflecting Dr. Murea's commitment to advancing patient-centered care and improving outcomes for those undergoing hemodialysis. Dr. Murea, welcome to the program. I'll turn things over to you.
Thank you very much for this introduction. I'm very grateful for being here today and to speak to the broad kidney community about the research that myself and many other investigators are doing through the 2+ clinical trial. So the main topics that I will discuss with you today are residual kidney function, conventional hemodialysis, incremental start hemodialysis, and the research that studies these two different approaches of dialysis initiation, which is conventional versus incremental start. And throughout the presentation, you will see some abbreviations: HD for hemodialysis, RKF for residual kidney function, PD for peritoneal dialysis, PCORI for Patient-Centered Outcomes Research Institute. And so before I start, I just want to get acquainted a little bit with the audience. So I've been a practicing nephrologist for 15 years, and as I said, I'm studying this gradual approach to dialysis initiation. So I wanted to see in the room how many people were treated with in-center hemodialysis or are currently treated with in-center dialysis. By a quick show of hands, anybody? Was okay, thank you. And who were you treated with? Actually 3 sessions per week when you did in-center hemodialysis, or fewer sessions and then moved up to more sessions? Was it 3 sessions or, yeah? All right, thank you. Well, we'll get back to this as we move along. So I'll start by sharing what sparked my interest in the way we practice chronic hemodialysis. So over the years, I've taken care, and I'm taking care of many people with advanced kidney disease who end up needing to start dialysis. And as I was rounding at the outpatient dialysis centers, I saw people who had very different clinical manifestations. So some people were on dialysis for just 1 day, or for 5 years or 10 years. Some people were saying that have no urine output. Some said that they have some little output, and some said that they urinate just fine, right? They had normal urine output. And some people would gain significant amount of fluid between dialysis treatments, some low amounts and some none. So all the time, as I was seeing people who had very different clinical manifestations, I was there to prescribe just one treatment, hemodialysis 3 times a week, each that needed to be delivered at a minimum intensity or higher, right? We call that single pool KD/V for urea toxin clearance. I further noticed that there was actually a clinical correlation between the duration of dialysis and the amount of urine that the people were saying that they produce, such that the earlier they were in the beginning stage of their dialysis period, the more urine that they were saying that they produced, and the more urine they were making, or earlier in the stage of dialysis, the fewer clinical manifestations they had in terms of how much fluid they would gain between dialysis treatments and other laboratory findings. So I wondered, is it right to just be there and see so many different people, so many different manifestations, and treat everyone with the same dialysis prescription? And the fact that I was giving dialysis as a quote-unquote kidney replacement therapy to someone who makes no urine at the same dose to someone who has urine output seemed a little bit counterintuitive to me. So, and believe it or not, obviously people who start dialysis, hemodialysis including, do have urine output. And we have even a name for that kidney function when dialysis starts and while the people are on dialysis. It is called residual kidney function, or RKF, here on this slide. And now, naturally, residual kidney function after dialysis goes down. So some people at the beginning of dialysis have appreciable amount or good amount, later on becomes modest or low or even absent. So residual kidney function tends to decrease after dialysis starts, just as it decreased before dialysis started, because dialysis is not a cure for kidney weakness or kidney failure, right? And we also actually can quantify this residual kidney function by asking the patients to perform time during collection or 24 hours during collection, which we actually do for people who choose to be treated with peritoneal dialysis, right? So if a person chooses to do peritoneal dialysis, we adjust actually the peritoneal dialysis prescription according to the level of the residual kidney function. We start with fewer dialysis exchanges at night, fewer dwells or smaller fluids, and in time, as the residual kidney function declines and the clinical manifestations change, we go up on the peritoneal dialysis prescription. We put more dwells, maybe a last backfill, what we call, or like dialysis during daytime. Now, if if the person were to choose to start hemodialysis, we would not even ask or quantify residual kidney function. So even if that person had residual kidney function, we would not look for it. And in fact, if somebody were to choose hemodialysis and hypothetically, let's say the next day said, I changed my mind, there's something that intervened with in my lifestyle, I prefer to do in-center hemodialysis, even if we quantify the residual kidney function beforehand, it would be completely ignored for the treatment with in-center hemodialysis. And it's not clear why the value of residual kidney function is so disproportionately considered just for in peritoneal dialysis and not at all in hemodialysis. And in fact, the residual kidney function is extremely valuable no matter what type of dialysis is provided, whether it's hemodialysis or peritoneal dialysis. People who have residual kidney function have better clinical manifestations, have better quality of life, and have better clearance of toxins that are not removed, cannot be removed by hemodialysis, and that is because kidneys can remove toxins that are attached to other larger molecules that don't pass through the filter of dialysis or through the peritoneal membrane. They also have endocrine function and immune function. And so should we also quantify and pay attention to this residual kidney function also, for people who choose hemodialysis, just as we do for people who choose peritoneal dialysis, and I think we should, but as of now, we don't. Virtually anyone who chooses to do in-center hemodialysis receives what is called conventional hemodialysis 3 times a week, and this approach to conventional hemodialysis is based on 2 landmark clinical trials called the HEMO trial and NCDS trial. Now, based on those trials, it is very clear that people who have very low residual kidney function with urine output less than 200 milliliters a day do better with conventional hemodialysis prescription 3 times a week, each delivered at a certain minimum dose, than if they were to be prescribed less intensive hemodialysis. But again, the people that were studied in these clinical trials included only those who had minimal or low residual kidney function. Now, there was another landmark clinical trial called the Frequent Hemodialysis Network Trial, FHN trial. They show people who receive more frequent hemodialysis 5 times a week do better than those who receive 3 times a week hemodialysis. Now, the common denominator among all these 3 landmark clinical trials that I said was the people had low residual kidney function, and they were on hemodialysis for months or years. And so this does not apply, though, these results does not apply to people who just start hemodialysis and who have appreciable amounts of residual kidney function, because this segment of population or this stage of dialysis was not specifically ever studied in the randomized clinical trial. So if we were then to pay attention to residual kidney function, could we prescribe dialysis gradually, in-center hemodialysis gradually, just as we do with peritoneal dialysis? And in fact, that approach to gradually prescribing in-center hemodialysis is called incremental start hemodialysis, or in short, incremental hemodialysis. So could we start with 2 hemodialysis sessions per week instead of 3 hemodialysis sessions per week, and monitor residual kidney function regularly and adjust the frequency or the duration of each treatment according to clinical manifestations, those clinical manifestations are in fact dictated by the level of residual kidney function, but it also depends on whether the person has other clinical conditions, and depends also on the diet. And then if and when clinical manifestations dictate or require, then we go up on to 3 times a week hemodialysis. So I'm coming back to our little dialogue, the little dialogue that I had with the audience before. So to say that I've been practicing incremental hemodialysis for almost a decade, and I started collaborating with investigators and clinicians and investigators in the nation and around the globe who have been practicing actually incremental hemodialysis for decades, almost ever since chronic hemodialysis became possible, like since 1980s, early 1980s. So I've learned that this approach to hemodialysis can work. We just need to prove to the broad community and all stakeholders that there is value in this approach. So getting back to my questions for the audience earlier, how many people in this audience have heard of residual kidney function before? Or incremental start hemodialysis? No. All right, good. Well, good and not good, so that's at least you're here to have learn about this. And so I want to share with you just briefly. I know this may be a little bit too science related, but just want to give you the information from my collaborators in Europe. So, for example, this group from Le Mans, France, has been practicing incremental hemodialysis also for decades, and recently they published their most recent experience of over a 5-year of all people who started dialysis at their institution. 60% of people started with either once or twice weekly hemodialysis. And those people, compared to their counterparts who started with 3 times a week, had similar survival at long-term follow-up after 5 years. This comes from Switzerland over a contemporary period of 8 years. 50% of the people started with conventional 3 times a week, a quarter, 25% with incremental twice weekly hemodialysis, and 25% started with peritoneal dialysis. The survival of people who were treated with incremental hemodialysis was better than those who were treated with conventional hemodialysis. And the urine output, when they compare between people who were treated with peritoneal dialysis and incremental hemodialysis, was similar. So that kind of debunked, as well as other studies debunked the idea that maybe hemodialysis, once the people start on hemodialysis, they lose their residual kidney function way too fast and it might be unsafe. So that kind of argument or thinking behind it has been debunked not only by the study but also other studies. And this is data from Italy. This group has also been practicing and is conducting currently also a randomized clinical trial in Europe. So they published their 9-year experience, most recent 9 years, and at their institution, 2/3 of the people in Italy start with incremental hemodialysis either once a week or twice a week, and then they move up to 2 times a week, or from 2 to 3 times a week, according to clinical manifestations, laboratory data, and residual kidney function. And again, the survival at 10 years was slightly better in incremental group, but not necessarily statistically significant, but it was not worse, that's for sure, right? So by now, probably many of you have several questions, and I have here 4 most frequently asked questions that I want to proactively address. So why would incremental start hemodialysis be of interest for the kidney community? Well, assuming that it is safe, and assuming there is mutual accountability in the relation between the patient and the physician, that the recommendations are followed, then of course it should be of interest, I would say, right? Is sort of who wouldn't want to be treated with an amount of treatment or dialysis that is actually only necessary for their stage, for their condition at that time. It would lessen the anxiety or depression or the burden that dialysis brings when a person needs from the get-go, from the outset, to be on 3 times a week, maybe on less frequent, and then in time as needed, then it could be moved up. also the costs for dialysis-related treatment, and maybe and the caregiver burden would lessen. Not to mention the hemodialysis procedure itself is very difficult to tolerate. So, of course, why get it unless it's absolutely needed? So hemodialysis has been shown that it can cause ischemia or weakness of the heart, the brain, and other organs. So we want to be very cautious when we recommend this treatment and how much we recommend it. Who would be eligible for incremental start hemodialysis? As I referred to earlier, this approach, incremental start, is rooted in the fundamental principle of medicine of giving treatment at a dose that aligns with disease severity. So treatment intensity needs to align with disease severity. In this context, disease severity is residual kidney function, along with clinical manifestations that go hand in hand. So people who would have sufficient residual kidney function could be treated with incremental start maybe twice a week, and then later in time, or they would be on 3 times a week. Sometimes people need even more frequent hemodialysis, and they don't need to be always stuck in one treatment. They could go from 4 times a week temporarily back to 3 times a week, which depends on their either medical conditions or their dietary changes. So how soon would a person need to move from 2 times a week to 3 times a week? It varies from an individual to another. In general, the average time to transition from 2 to 3 is about 8 months, but some people, it ranges anywhere from 2 months to 2 years or so. And that it depends on the initial level of residual kidney function, underlying cause of kidney disease, other concurrent medical conditions, if they develop an acute medical condition that causes an acute kidney injury, dietary load of salt and red meat. And how safe is incremental hemodialysis? So this is a meta-analysis, or it's sort of like a summary of all data that is out there now, which is about 22 observational data and 2 pilot studies. It showed that it is as safe in terms of survival, as safe as conventional start, but potentially fewer hospitalizations. Now, you might ask, well, based on this data, why are we even questioning this, or what's the discussion here about? Well, there are limitations that have been brought along this line of evidence, that most evidence comes from other countries and also from being observational. So maybe it's biased, maybe it was offered only to people who were believed to follow the recommendations by the doctor, so maybe perceived to have different adherence to medical recommendations. So what we want to do with our study is to take it to the next level, bring unbiased evidence, maybe to convince all stakeholders in the kidney community. So such that if someone has a certain level of residual kidney function and medical conditions that are well stabilized at dialysis, soon after dialysis initiation, like within 3 months, and they still have good residual kidney function, can they go to 2 times a week, be monitored, and then move to 3 times a week when needed according to clinical manifestations? Or how would they do if they were otherwise going to stay with 3 times a week hemodialysis? So now that means randomized clinical trials, right? So you get a cohort of people who have similar clinical characteristics and residual kidney function, and then they would have an equal chance of then continuing to 3 times a week, or switching to incrementals, or to 2 times a week and then 3 times a week. And there are currently 6 randomized clinical trials that are taking place. 4 of them are in Australia, Canada, and Europe, and 2 of them are here in the United States. One of the 2 in the United States is being conducted amongst veterans population, and the other one is conducting amongst non-veteran population. I work on the one that is conducted in a non-veterans population. It's called the 2+ trial. And so we include in this clinical study people who have been on dialysis for less than 3 months, make 500 mLs of urine a day, and have a kidney urea toxin clearance of at least 2 milliliters per minute. Our objective is to bring unbiased evidence on the effectiveness of incremental start hemodialysis relative to that of conventional hemodialysis. So we aim a recruitment of 350 patients total. So if they have the level of residual kidney function that I just mentioned, they would either proceed to 2 times a week, 4 hours each treatment, and then have residual kidney function monitored, clinical manifestations and labs, and then transition or progress to 3 times a week when medically necessary, or continue with 3 times a week hemodialysis. We also enroll their caregivers. And throughout the study, we monitor, as I said, residual kidney function laboratory data. We track all clinical events, emergency department visits, hospitalizations, adherence to dialysis prescription, and we obtain patient-reported outcomes through questionnaires, as well as caregiver-reported outcomes, also through validated questionnaires. And we plan to interview patient participants, caregiver participants, and physicians and dialysis personnel to gather different perspectives about this approach to initiation of hemodialysis and how it can get incorporated into the usual workflows at the dialysis centers. Now, to get this funding from PCORI, we partnered with many different organizations. From the stage of when we conceptualized this study, we partnered with AAKP and Home Dialyzers United. We partnered with patient representatives, patients and caregivers, and physicians from more than healthcare systems. So we are truly, truly grateful that we had their partnership and their collaboration, because that made it possible and convincing for PCORI, which is a reputable funding agency that funds comparative outcomes research to help patients make an informed healthcare decision. So with their help, with everybody's help and engagement, we put a proposal to PCORI, and it got approved in last year in 2023, in February 2023. Then we also partnered with 5 dialysis organizations, and I'm really grateful. I want to extend a lot of gratitude to the 2 large dialysis organizations who are making a big investment in the future of hemodialysis care, and the 3 university-owned dialysis organizations. All these 5 dialysis organizations invest in the future of hemodialysis: Fresenius, U.S. Renal Care, Wake Forest, University of Virginia, and Emory. We have accomplished several milestones so far. So from the beginning, we developed patient-facing materials and study protocol with input from patient representatives and AAKP. AAKP also sits in the Data and Safety Monitoring Board. We also designed websites for the patients where we have an overview of the study and how time during collection is performed. We performed training of the local treating providers and dialysis personnel across more than 50 dialysis centers that participate in this study, and we started recruitment this year. Now, that doesn't mean that we don't have challenges, and the recruitment is running slower than we expected. We are working on expanding the consortium by adding new sites. Now, of course, we have challenges with this. We were like, for example, the current reimbursement system and quality metrics make it such that incremental start hemodialysis is not very appealing to everybody. So we hope to, and we will, surpass the challenges that we have ahead. So in summary, some people who are treated with, who choose to be treated or choose to do in-center hemodialysis have residual kidney function at appreciable levels when they start the treatment. Conventional hemodialysis has been studied in patients who have low residual kidney function. It is conceivable that incremental gradual start hemodialysis, similar to how peritoneal dialysis is prescribed, would be safe and favorable for people with residual kidney function, and we're conducting the 2+ trial to bring more compelling and accurate data on the effectiveness on incremental start hemodialysis. And our mission is to refine hemodialysis as an individualized and flexible treatment. And so hopefully we can improve the experiences and outcomes for people who choose and who need in-center hemodialysis. Thank you very much for your attention.
Dr. Murea, thank you. Thank you for an excellent presentation. I'd like to open the floor to our audience to ask questions.
And I think your study is very relevant. And my two questions to you are, in terms of getting patients to consent and to agree, is, in terms of educating them about the benefit of residual renal function, is there a barrier where, when a patient feels that they've approached ESRD, when they've gone from CKD5 on, that they feel that it's inevitable? There's an inevitability about, having the kidneys completely fail. And, transplant is, of course, an option, as well as other renal replacement therapy like hemo and PD. But, they say, well, why should I do this? Why should I inconvenience myself by getting 24-hour urines and measuring, my residual GFR? If it, in another few months, it's going to go away and I'm going to be on it anyway. The second is, in a situation where it was an ideal world and, large dialysis organizations were getting reimbursement per session, is it difficult to get them to agree to a protocol where you're reducing 3 times a week to 2 times a week, when maybe, essentially it could be incrementally better depending on the results of the study for your patient, but it's not incrementally better for them financially? And then my third question is there a strategy, or you've contemplated, if you're doing incremental dialysis, is there any way of ascertaining whether, by taking perhaps work off the kidney or removing some additional toxins, or for whatever reason, maybe the mechanism is yet to be elucidated, that you're preserving residual renal function by doing what you're doing? Or is it just an exercise to see how it impacts on the dialysis prescription?
Thank you very much. Those are excellent questions, and I might break them into 3 questions. Maybe the first one is, when we are approaching the patient for this study, do they feel deterred to participate in the study if they are hearing, well, even if I go to 2 times a week, I might need eventually to go to 3 times a week anyhow. Why should I consider doing the study? Am I understanding correctly? Is that a question? So typically we have not found necessarily that people would say, no, I would rather take 3 times a week from the beginning, even if I could do 2 times a week for 2 months or 3 months or 4 months or 5. I mean, I think it is, each hemodialysis treatment is very taxing for a patient. So we have not had that line of argument from a patient. Now, the patients refusing to participate does not come, the main reason is not because they would rather not bother and do initially fewer treatments and later more treatments. It's more of that they feel overwhelmed with the healthcare system. They find it very difficult to navigate, and it's the idea of any research for them is just too much to handle, having, just going through the initiation of dialysis and just even healthcare system in itself. So that is a burden for them, but it's not because they said, I would rather do more than less. And now the second question, maybe that was a little bit embedded in the first question, is your first question was, are there challenges in getting the dialysis organizations to collaborate with us in this study? Is that correct? Because of the reimbursement repercussions? Yes, so that was one of the challenges, indeed, also that I mentioned on the slide. Evidently, I mean, that's a very big challenge, without a doubt. I mean, what can I say? I mean, we have to be understanding that the dialysis organizations need to offer a salary for many people who are employed for them, right? They have had a lot of challenges themselves. They closed dialysis clinics by hundreds in numbers lately. So I am very admirable of what they do for the community, and I'm explaining that this treatment may also, while at face value may be a finance negative treatment, it could be actually the answer, because the workforce shortages are ever growing. Dialysis centers are being closed, and some people need more dialysis or more flexibility in when they need to come to dialysis rather than hitting the emergency room because they couldn't fit in at a different time slot at the dialysis center. So having this treatments where the staff to patient ratio can improve by offering some people less at the beginning if they can, it could actually be the answer to other difficulties that the dialysis system is encountering, which are major difficulties, as we know. So that's my answer to number 2. Number 3 was, remind me your second question, I'm sorry.
Yeah, so the third question is, you look at the impact of
on the preservation of residual kidney function. Yes, correct. Thank you so much. So as of now, it's not known whether incremental hemodialysis per se would preserve better residual kidney function. The reason for that being that now we're starting to measure it. We don't measure usually residual kidney function in hemodialysis, and we don't know whether less hemodialysis or just the underlying cause of kidney disease would still have the same impact on the rate of progression of kidney failure, or other concurrent illnesses, infections that happen, heart attacks, because any acute illness on top of everything else would deteriorate the residual kidney function. So it's not as much as incremental hemodialysis being let's preserve the residual kidney function, let's pay attention to it and incorporate it, just as we do in peritoneal dialysis. We're not measuring residual kidney function and incorporated it in prescription because we preserve residual kidney function by peritoneal dialysis, because we're looking at it, we're paying attention to it, and obviously if we pay attention to it, then even other physicians will pay attention to it by refraining from ordering nephrotoxin medications or contrast, just like we do in patients who are treated with peritoneal dialysis. It's exactly the same concept. But definitely that will be one of the outcomes in comparing the residual kidney function trajectories between treatment groups.
One time it was suggested, for example, continuing an ACER and ARB to try to maintain that would make sense. I don't know if that's gained any credence at all.
Yeah, we definitely continue ACE and ARBs in people, even once they start hemodialysis, no matter the residual kidney function, just like we do with peritoneal dialysis. Those are very important for blood pressure control and cardiovascular protection. So absolutely, studies have shown that if we withdraw those medications, cardiovascular outcomes worsen. So no, those should stay. The cardiovascular outcomes are extremely important. We do, though, continue diuretics. We make a great point of continuing diuretics and increasing the dose and giving them on non-dialysis days. Would you use just Lasix, or would you go to Zeroxolin or ethylenic acid? Yeah, it depends from a person to another. So often, the furosemide at good, considerable doses could be enough, or bumetanide, and sometimes we add Zeroxolin, but so it depends from a person to another, depending on their volume status and what diuretics they were on before they started treatment, what their interdialytic weight gain is, what the diet, obviously the diet plays a big role. Yeah. Thank you very much. Sure, thank you.
I just wanted to thank you. As someone that has done hemo and peritoneal, I've kind of been through the protocols and all of that, and I really wish this was something that was available when I was on dialysis, just an option to really, because I was one that urinated the entire time, and I always question, like, why am I doing the same thing that someone sitting next to me that had to stop urinating? Exactly. Why are we doing the same treatment? So I just wanted to thank you. When we talk about patient-centered care and all of that, there should be options available, because it's not a one-size-fits-all approach, or it shouldn't be, but many times it is. It's like, okay, we all go do 3 days, and no matter where you are in the continuum, we're going to all give you the same thing. So I feel like this is very intentional and really meeting patients where they are. It's already a very devastating and traumatic event to start dialysis. So the thought of doing it incrementally, I think, is great. So thank you so much.
Thank you. Thank you.
Okay. Thank you, Dr. Murea. Again, we want to extend our heartfelt thank you for your incredible presentation.
Can I ask her a question?
Oh, sorry. Yeah.
I had my hand up. Sorry. I have a question real quick. My mother has been doing incremental dialysis twice a week for the last 4 years, and her kidney functions have been pretty decent. I was wondering, what would be the benefit of doing home hemodialysis? What would be the cardiovascular benefit of transitioning to home hemodialysis? So
transitioning to home hemodialysis, which also actually, even at the beginning of home hemodialysis, can also be prescribed incrementally, by the way, but that's sort of a relatively different topic. So, but now from the in-center, with 2 times a week, to home hemodialysis, one thing could be that I don't know how long her sessions are now for 2 times a week, and whether she, at being 4 years now into doing 2 times a week, maybe the interdialytic fluid gains have increased a little bit. So one benefit would be that she could do shorter sessions 3 times a week at home, and if the fluid gains, because especially if the fluid gains have become a relatively a problem, then she would unload that from the heart more of at a steady state. Most often, the reason for transitioning from 2 times a week to 3 times a week is the fluid gain. It's not potassium, it's not phosphorus, it's not whatever bicarbonate. We can give that, we can or PTH. We can take care of those also with medications. But fluid gains, when the kidneys become quite weak and don't respond anymore to no matter what diuretics, that is the problem. So that would be, yeah.
Thank you so much.
Sure.
Terrific. Thank you so much again, Dr. Mariana.